Welcome to the first symposium of the Sri Lanka Surgical Congress 2023. A symposium in the field of hepatopancreaticobiliary surgery, and we'll be looking at, it's a symposium that's very topical, and we'll be looking at, we've got a panel who's going to discuss surgery for colorectal liver metastases. And to begin the introductions of our expert panel today, I'll hand over to Professor Aloka Patirana.
So good morning, everybody. So today we have an elite panel to discuss colorectal liver metastases. So I'll introduce the person on my right, Professor Rohan Siriwadana. He is a professor in surgery at University of Kelaniya, and he has been in the field for over 10 or 15 years as the GI surgeon specialized in hepatobiliary surgery plus liver transplant, and I think he's no stranger to the audience. And let me also introduce Dr. Nurad Joseph, who is an oncologist, who is a young and upcoming oncologist who has a lot of interest in research, and I think he has a special interest in colorectal liver mets as well.
And we've got an international panel, two eminent hepatobiliary and pancreatic surgeons from the UK. Professor Rowan Parkes is the president of the Royal College of Surgeons of Edinburgh, professor of surgical sciences and an honorary consultant surgeon at the University of Edinburgh. He's no stranger to this audience as well. He's been here several times, and we are really glad to have you, Rowan. He's the current General Secretary of the International Hepatopancreaticobiliary Association and the past President of the Association of Surgeons of Great Britain and Ireland and the Great Britain and Ireland Hepatopancreaticobiliary Association. Joining him is our own, I hope you don't mind us calling you our own Mike De Silva, consultant hepatobiliary and pancreatic surgeon currently at the Oxford University Hospitals NHS. He's the training program director for higher surgical trainees in general surgery at the Oxford Deanery, and was is the director of the Surgical Advisory Network in the UK for the Royal College of Surgeons of Edinburgh. He's a clinical lead for HPB surgery in Oxford, and he established the Oxford Pancreas and Liver Fund within the Oxford University Hospital. So as you can see, we've got a stellar group who's going to take us through something or what is topical today in hepatopancreaticobiliary surgery and specifically colorectal liver metastasis. I'll start off by handing over to my colleague Rohan, who's going to talk about the Sri Lankan experience and story in the management of colorectal liver metastasis. Over to you, Rohan.
Thank you, Siva, and very good morning to all of you. First of all, let me thank the organizing committee for giving me this opportunity to talk a few words about what's been happening in Sri Lanka. I thought rather than talking too much about technical details on the treatment and the surgery for colorectal liver metastasis, I thought probably I'll just try to take these 15 minutes to discuss about how far we have come during the last 10-15 years, what problems that we have, and how possibly few strategies to overcome these problems that we have in developing HPB surgery and liver surgery in Sri Lanka. Let's look at a bit of history. In fact, management of colorectal cancer has actually, field of colorectal surgery started developing in Sri Lanka before HPB surgery. And these are the two pioneers in the field, late Professor Dayasiri Fernando and Professor Arjuna Alivihare. Around early 80s, they started pioneering the field of colorectal surgery. Around that time, I can remember as a medical student, when we see patients with liver metastasis, my consultants used to say, this patient is not curable, and we are offering him palliative treatment. Around that time, there were few surgeons who attempted surgical resection for liver, but the outcomes are extremely poor. But it's this man, Professor Aloka Pathirana, my teacher, who started pioneering in the field of liver surgery in Sri Lanka. In 2010, I can still remember as a young registrar assisting him doing liver resections with Kelly clamp and bipolar diathermy. And there were a lot of us who got inspired by working with him. We had training, formal training, overseas training, and we returned to Sri Lanka from 2010 and 2020 onwards. Things have been moving formally. So right now, there are at least, I'm talking about the surgeons who had formal HPB training, minimum 3 years of local overseas training. There are 6 HPB surgeons with general surgeon, specially interested in general surgery and HPB, and 3 GI surgeons, at least 1 oncosurgeon, and few vascular surgeons who perform liver resections. And Sri Lanka, there are at least 4 centers that perform more than 20 liver resections annually. Peradeniya, Colombo, there are 2 centers, Colombo South and General Hospital. And I'm from Colombo North Teaching Hospital, and we perform around 40 liver resections annually. Apart from these 4 main centers, there are 3 centers that perform lesser number of liver resections from Kurunegala, Badulla, and Galle. Now let's look at few data that was published on colorectal cancer. Now this data is coming from Colombo Group, where they have looked at the National Cancer Registry, comparing the incidences in 2001 and 2010, and they reported that the incidence of colorectal cancer across all the age groups has increased. This is another interesting study that was published. It's actually comparison between a Sri Lankan cohort of patients with colorectal cancer and a European cohort. And this paper is available as a thesis in Gothenburg University website. And when they compared the incidences in Europe and Sri Lanka, they found that in Sri Lankans, colorectal cancer was seen at much younger age. And similar results were published by our own colleagues from Ragama. They found that almost 26% of the patients were younger, less than 50 years of age, ones who had colorectal cancer. So what does that mean? It means that these patients are younger, possibly their tumors are much more aggressive, and we have to follow them up for a longer period of time. Now, what have we published? What reports do we have on liver metastasis? This is one of our early publications. When we looked at our colorectal database, this is a colorectal database, not a HPV database, we saw that the incidence of synchronous metastasis was around 8% out of all the patients who had colorectal cancer. And this is 10 years later. This paper is accepted for publication. We looked at the 78 patients who had liver resection, who were followed up for minimum period of 5 years. And we saw that the primary rows, in the left side in about 90% of the patients from the left colon, and synchronous metastasis was seen in about 61%. And large majority had bilateral tumors, and about 34% of them had single liver nodules. And when their survival was assessed, they had a recurrence-free 5-year survival was about 25%. So that is the data that is available from Sri Lanka. Now let's look at the kind of patients that we might get for management. Now this is a patient who was referred to us. This patient had a right colon tumor, and there were 4 liver lesions. There were 2 lesions in the left lobe, and 1 lesion was coming very close to the middle hepatic vein. But there was a reasonable gap between the middle hepatic vein and the tumor nodule on the left-hand side. And there were 2 nodules in the right posterior sector, but the tumor was coming very close to the right hepatic vein. And the segment 5 and segment 8 was free of tumor. The segment right anterior sector volume was around 210 milliliters, and there were quite sizable veins draining the right anterior sector into the middle hepatic vein. So when a patient like this comes to us, the patient will undergo volumetry because this seems to be a critical, volume seems to be critical. And we do perform MRI scans in all these complex cases because sometimes our CTs might miss small lesions, and we do not have access to PET scans readily. We do KRAS status for post-operative possible chemo, and usually we do liver spleen attenuation index because fatty liver disease is very common among our patients, and of course we do a detailed cardiac assessment. And once this assessment is completed, the patient was discussed among the radiologist, our oncologist, colorectal and HPB surgeon, and the anesthetist, and discussed the possibilities about palliative chemotherapy and possible right posterior section to combine with ALS procedure, or maybe offering neoadjuvant chemo and reassess. But eventually we decided to offer left hepatectomy, preserving the middle hepatic vein because we felt that the middle hepatic vein was critical, and then combining that with right posterior pedicle portal vein ligation because it was accessible from the hilum, and combine that with right hemicolectomy. And patient was referred for chemo, and possibly we will reassess and offer this patient later a right posterior sectionectomy. So this is a kind of patient that we are talking about. It's a multi-step process, and multiple specialties are involved in management of these patients. And we can actually stretch the boundaries of HPB surgery when you treat these patients with colorectal cancer liver metastasis. So what does that really mean to our patients? Now, this patient was referred to us from Badulla, far away, about 250 kilometers from Colombo. He has to travel another 2 hours to come to Badulla main bus station. And altogether, he has to travel about 10-12 hours taking bus to come to Colombo. And these patients, most of them, they have never been to Colombo. First visit to Colombo, and they don't have anyone in Colombo. And you know, in our setup, to get a CT scan done, to get a referral done, he has to be in the hospital, come to hospital many, many times. So what the point that I'm trying to highlight is that this is a very complex multi-step procedure. And socially, our patients sometimes are not capable of handling these kind of multi-step procedures. And I've seen many patients, we start the treatment and in midway they drop out. So what I'm saying is, it's not that we should not offer these treatments, these complex treatments, but we should establish some form of support system for our patients in order to continue this treatment that we are offering. So another important aspect that I would like to highlight. Health-related literacy is your ability to understand health-related matters and use them for your benefit and the benefit of people around you. And this is an interesting study that was done in Colombo. These authors, they looked at teachers from Colombo. Mind you, teachers are the ones who educate our young ones. And they are expected to have a good health-related literacy. But when they looked at the health-related literacy, it was about 26% of them, it was not up to the standard. And 4% of the Sri Lankan population, only 4%, belong to the middle class. And large majority of Sri Lankans are from rural communities. And you can expect the kind of health-related literacy that they are going to have. So we are explaining this complex procedure. Sometimes even the medical professionals may find it difficult to understand. And most of this information that we give to these patients, they don't understand what we are talking about. So it's art, especially I think as trainees, it's important to understand the practice of medicine in our context. And you should learn the art of giving required information in a way that the patient understands is very important in managing patients like this in our context. Now let's look at consultants and doctors. Now in Sri Lanka, liver resections are performed. Liver resection for colorectal metastasis and liver resection for any other disease are performed by general surgeons with HPB interest, gastroenterological surgeons, oncosurgeons, and vascular surgeons. And we have been arguing and discussing about the kind of training that we should provide to our trainees. And we don't seem to come into a consensus, and the common way looks like everyone prefers their own specialty to decide on the training within their specialty. But having said that, the kind of treatment that, or the competency of liver resection that is offered by oncosurgeon should be comparable to a general surgeon, should be comparable to a general surgeon with HPB interest. So what I'm trying to say is that as a patient doesn't really bother about your specialty. Patient is really concerned about the outcome and your competency. And the competency that you should try to achieve should be uniform across all the specialties. So how are we going to achieve this? There are two ways of looking at this. Either you can allow each specialty to decide on their training. But I think fundamentally that is wrong, because at the end of the day, everyone should have equal competency. But I think a more rational way of looking at it is we can standardize an index or a kind of surgery that we are going to perform and say, okay, this is the minimum requirement for you to perform this surgery, and that should be uniform across all the specialties. So that's another area that we have to think and establish firm grounds in our training. Now, I would like to take up couple of cases and highlight two other problems that we face when we manage these complex cases. This patient was referred to us, he came to us, referred to us for the management of a hemangioma. He was diagnosed of having a sigmoid colon cancer. He had low GI symptoms, underwent colonoscopy, and biopsy proven sigmoid colon tumor. And patient underwent a CT scan. It was only a venous phase CT scan. And this is exactly what the report said. It was commenting about sigmoid colon tumor, but it also said focal lesion suggestive of a hemangioma. And the patient underwent sigmoid colectomy, and patient was referred to us for the management of the hemangioma. So it's important, surgery actually has started subspecializing, and surgeons have accepted the need of subspecialization and has started to subspecialize. But with the surgery, other supporting services should also improve. Radiology, pathology, interventional radiology should also start subspecializing. If not, problems like this can happen, and we may not be able to offer optimum care for our patients. This is again a similar patient. This patient had anterior resection 2 years ago. He lost to follow-up, and all of a sudden, patient turned up with this CT scan. And the CT report said multiple liver metastases from a known primary. Actually, this patient was discussed in a multidisciplinary meeting. And the multidisciplinary meeting, or the consultants who got together, decided, okay, it says multiple liver metastases, and this cannot be operated, and patient was offered palliative chemotherapy. So it's good that we are discussing our cases in multidisciplinary meetings, but it also, as a next step, we should also improve the standards and the quality of the opinion that we give in these multidisciplinary meetings. And this is another area that we should think about in the future when we think of progress of surgery in Sri Lanka. So we have come a long way in HPB surgery during the last 15 years, and we have come to an important critical point. And now we face different type of challenges. If we have to read the summit of HPB surgery, we need to overcome these challenges. Otherwise, we will be stuck in the same place in the future as well. So what can we do? I think we need to standardize our training. I think we need to standardize our treatment as well. And also, I think we have to offer, or we have to take decision in a Sri Lankan context. So that brings to the end of my brief talk. I have 3 more cases, actually. I think if we have time, after listening to our colleagues, we can take up these cases and discuss if we have time. Thank you very much.
May I now invite Mr. Michael Silva to deliver his talk on training a liver surgeon.
Thank you, Aloka, and thank you, Nandadeva and Siva, for personally inviting me to this forum today. Good morning, folks. I think I can't let this opportunity go past without mentioning the sentiments that I like to. I stand here today as a council member of the Royal College of Surgeons of Edinburgh. But I'm also here as an alumni of this college. I am a past pupil of this medical school. And it's here in these premises that, although it's not in this fancy building that you have today, but an old anatomy block that occupied this premises previously, that I learned my anatomy, my physiology, I learned my surgery. I learned how to examine a patient and how to treat my patients with compassion. And in a forum very much like this, many years ago, I have sat in the audience as a junior trainee. and listened to the likes of Rowan Parks and Neil Mortensen, council members of the Royal College of Surgeons, and thought to myself how abstract these people are, how much apart our worlds are. And what I'm trying to tell you as trainees and students here is that never think the impossible is unachievable. Always follow your dreams. I'm here also as an educator because I'm the training program director for general surgery, the higher surgical trainees in the Thames Valley Oxford Deanery. And I'm also here as an HPB surgeon to talk to you about training. And I've slightly changed the topic to HPB surgery because liver surgery is not trained as a separate specialty in the UK. And when I was thinking about giving this talk to this audience, I came across this paper that describes how HPB surgery happens, the training of HPB surgery happens in North America. And it highlights everything that I think is important, and some of it that Rohan alluded to in his previous talk about the best care that a HPB surgeon can and should provide. And this is a surgeon who has to be trained to attain a very high degree of technical and operative ability, while understanding the importance of all the available treatment options, considering those options carefully and what is appropriate for that patient in the setting of a multidisciplinary approach. And that is what's key to, I think, the training of this surgeon. And while the training of North America is applicable to that region, it may not work for the UK. And he's highlighted the difficulties and the challenges that can be seen in this country. So when you are considering training a surgeon for the role of an HPB or liver surgeon, you need to look at what your country needs. Now, in the UK, we have a population of over 67 million, and we've got 22 designated HPB centers, 6 of which also carry out liver transplantation. And the GBI-HPBA and our Association of Upper GI Surgeons in the UK have mandated a minimum number of cases per surgeon per year in order to maintain certain standards. The standards are that you should be competent enough to do this challenging, technically difficult job. And these numbers are not prescriptive, but there is some degree of scrutiny that happens. And for example, my results can be found on this quality investigator that the NHS uses. And I use these outputs for my appraisal every year to show how the performance matches up to other HPB surgeons in the country. And it has also very important metrics that tells us what the 30-day mortality, for example, is per unit. And it's usually useful to know what the unit mortality is, what the unit volume is, and the outputs that are there. So there is a degree of scrutiny that happens. We call it peer review. And that happens in order to maintain standards that then are transmitted to our patients as quality care. There's also a change in the environment, a change in the landscape that occurred over the last few years, and the curriculum and how we train our trainees have evolved to what it is today. And the key changes are that training in the UK now happens in phases, and there are some terms that are used in this training that were not previously familiar to us: generic professional capabilities and capabilities in practice. And these are then looked at levels of competence that you gain going through your training. And what is the emphasis today is largely based on competence rather than time spent in training. So numbers are looked at, but it's looked at in a much more logical manner. And the trainees are then assessed in what is called a multi-consultant report. And we used to use a system of work-based assessments and used to stipulate a degree or numbers that were required for a trainee to have per year. And that is less of an importance in the current curriculum. So just to go through the phases that occur in a trainee's evolution through surgical training, you've got 3 phases, and phase 1 is core training, SHO training in all money. And you have to complete that training and also your MRCS in order to go into phase 2 of your training, which is ST 3 to 6. And this indicative 4 years is where you will learn and train in elective general surgery, emergency general surgery. And the emphasis is really in the bread and butter, this aspect of your surgical training. But at the same time, you are introduced to the subspecialties, and it's there that you develop your interests that will then take you on to phase 3. And there are certain hurdles you have to get across in order to move from phase 1 to phase 2, and then from phase 2 to phase 3. And phase 3, there are 2 indicative years, and there is a greater emphasis on specialty training at that stage. So if you want to be an HPB surgeon, that's where you get your bulk of HPB training, and then you go into your completion of training your CCT. So just to familiarize yourself what generic professional capabilities are, and these are 9 domains, and there's a lot of emphasis on professional behavior, the skills you gain in communication, the knowledge, the capabilities to develop health promotion and prevention of illness, and also patient safety, quality improvement, research, and so on and so forth. And these are looked at each stage of your training and assessed in a very schematized manner. And this is something that is really important in making that complete surgeon who gives a holistic approach to their practice. In addition to that, the capabilities in practice, looks at every aspect of your patient care, how you manage your outpatient clinics, how you do your emergency takes, the ward rounds, managing an operating list, and working in chairing a multidisciplinary meeting, for example. And at phase 2, you would be expected to achieve a certain level, and these are benchmarked against drop-down menus that gives you good examples of as to how the trainee is achieving this. And you'd need a level 3 or 2B to move from phase 2 to phase 3, for example. And at phase 3, if you are to achieve your completion of training, you need to be ready as a day 1 consultant, and that is what level 4 competencies would be. In addition to that, operative ability is also looked at very carefully, and the indicative numbers that you need are also stipulated and assessed, especially at crucial points. And as you can see, the levels of technical ability are clearly defined. For example, at level 3, you're trusted to act and operate with indirect supervision, whereas in level 4, you can be trusted as a day 1 consultant. And how does this assessment occur? It occurs every year, and I've just concluded what we call the annual review of competence and progression. It's called an ARCP, and this happens every year, where you go through a trainee's portfolio in detail to assess if these competencies these soft as well as hard skills have been gained and there is improvement within it. There are certain aspects that are really mandated and certain aspects that are less so. The multi-source feedback and the multi-consultant report and index operations are looked at very critically. And at the same time, you need to get through exams to go through certain hurdles to progress from a phase to another. There's an educational supervisor's report that is looked at, and then you get your sign-off at an ARCP to progress from one year to another. And how the year is looked at is also at the start of a year, you would have an objective meeting with your educational supervisor, and then there's a mid-year review, and at the end of the year, you have a final MCR. So all of these are done so that you set your goals at the beginning of the year, you look at how your progression is in the middle, and then it's reviewed as to whether you achieve that at the end of the year. So just to give an example of the operative competence one would require in HPB surgery, this is the checklist that I've gone through of a trainee who was signed off at level 4 at CCT, who's taking up a job at King's College in London as an HPB surgeon in 2 weeks' time. And if you look at the numbers that are mandated that this trainee is required to do and the numbers that he actually has achieved, you can see that there is good enough evidence to show that he has achieved these competencies during his time in training. And this is numbers that are cumulative over his 6 years in higher surgical training. And in HPB surgery, again, you are expected to carry out 35 complex procedures. He had done 82, and the cholecystectomies he had done 226 over that duration. And in addition to that, for your phase 3 sign-off, you are also expected to have 3 index procedures that are given in this list completed at level 4, and those are expected to be signed off by 3 separate assessors. And this we look at very, very carefully to make sure that this level of competence has been reached. And there are trainees who haven't achieved this, who then require to have additional training in order to achieve that, to be signed off and progress through that. And as you can see, liver resections, pancreatic resections, as well as cholecystectomies, this trainee had achieved well and beyond what was required at level 4. The liver resections and pancreatic resections, at present, we expect level 3 competence for sign-off. Higher surgical training, if a trainee declares to me that he or she wants to be an HPB surgeon, usually in phase 2, the trainee will be allowed 6 months as an ST4 in an HPB unit, and then return back to that HPB unit as an ST6 for further training. There is optional training that the trainee could do with a 3-year research project, and then return back in phase 3 to do a couple more years. And then that will take the trainee to CCT. Now, most of our trainees will also go into a post-CCT fellowship, and that is to get additional competence in HPB surgery. in addition to that pathway that I described, there's another pathway that you could achieve your registration as a specialist by looking at eligibility and competence that you've gained from other training programs. And both of these are pathways that will take you to a specialist register. Just a few words before I wrap up about post-CCT fellowships. Most, if not all, UK centers offer this. But it's really important to understand that that is for additional training and not for training in basic surgical HPB competencies. It is very competitive to get into these posts, and the applicants are predominantly from the UK, but also from Australia, New Zealand, South Africa, and the subcontinent. It is very unlikely that you will get shortlisted for these posts if you do not have HPB surgical experience. So what are the opportunities for someone who is training in Sri Lanka, for example, to get into an HPB program in the UK? And that's probably the most important, or what's foremost in your mind. The best option, as I can see in the current climate, is to get into a junior fellowship in HPB or a liver transplant center and gain your generic skills and then apply for a post-CCT fellowship. That is the best and achievable pathway at present. Things could change. You could also try to join a higher surgical program at phase 3, but there is no clear pathway to entry there. If you want to go into a post-CCT fellowship, it will be very challenging if you do not have previous HPB experience. So the majority of trainees who end up getting good hands-on training, where you have a good exposure and then a competent trainee at the end of that program, is probably going in as a junior fellow and then working your way towards a senior fellowship. Thank you.
Thank you, Michael. I now call upon Professor Rowan Parks. He's following on to tell us about the pathways of colorectal liver metastasis in the UK health system, following on from what Rowan did about the Sri Lankan system. Over to you, Rowan.
Thank you very much. It's a real pleasure to be here. Thank you to the organisers. It's lovely to be back in Sri Lanka. There's never been a randomized trial to show that liver resection for colorectal metastases has any survival benefit over other and alternative treatments, and yet it has been shown by numerous retrospective studies that there is a survival advantage, with 35 to 40% 5-year survival in selected patients who undergo liver resection. But that has been a very ad hoc arrangement, how that happens, how patients are referred, what their management pathway is, and it has evolved. And the indications for surgery and the boundaries of surgical excision or surgical resection of the liver has changed and evolved over the years. And because of that, a good 15, almost 20 years ago, a number of us in the UK tried to sit down and write the first guidelines for resection of colorectal liver metastases. And one of the key points and one of the recommendations was that patients under consideration of treatment of hepatic metastases should be discussed at a multidisciplinary meeting which has experience in the management of liver metastases. Because prior to that, a lot of the decisions were being made in colorectal MDT meetings, and some of those referral on to HPB surgeons varied, and the explanation and the rationale for that was also very variable. So what we proposed was that every patient with liver metastases should have some form of discussion with a liver surgeon. That was around the same time as a lot of cancer networks were being set up throughout the UK and in each of the devolved nations. So in England, Scotland, Wales, and indeed Northern Ireland, cancer regional networks were being set up to amalgamate clinical services, to define guidelines, and to help improve the outcomes of patients with predominantly primary cancers. And that became a challenge, and I'll come back to that. I'm going to focus a little bit on Scotland, based in Edinburgh. I guess it's where I've been more closely involved clinically with the evolution of referral pathways and referral networks. And in Scotland, we had three defined regional cancer networks: the West of Scotland Cancer Area Network, the North of Scotland Cancer Area Network, and the region that I work, the Southeast Scotland Cancer Network. And each of these had abbreviations: WOSCAN, NOSCAN, and SCAN. But for some malignancies that were of low volume, there were very small numbers in each of these three regional networks. And so for some cancers, and HPV cancer was one of those, it became a national network. There were others, malignant melanoma, and some of the rarer cancers were amalgamated into a national network. So for HPV, we had a national HPV cancer network that drew data from each of the three regional networks. Scotland has a population now of just over 5 million, and in that there are 5 centres undertaking HPV surgery. And we have decided at the outset to develop those into a managed clinical network. So the 5 centres work very closely. If we'd been starting with a clean sheet of paper, we would not have had 5 centres. And in fact, we've been in ongoing discussion with Scottish Government about whether this is the right model or whether we should rationalise. I think they have too many other priorities to make a judgment on that just at the present time, but that's what it is. So we have these 5 cancer centres, and that's important not just for the primary surgery, but also for the delivery of neoadjuvant and adjuvant chemotherapy, because that's where they are delivered. One of the challenges, and the biggest challenge we've had in HPV surgery, is that our cancer networks have been set up and both administratively and financially supported only to look at primary cancers. And this is where colorectal liver metastases becomes a real challenge, and it's been almost a 20-year battle to get colorectal liver metastases recognized as an important area of practice for the HPV surgeon. Now, 3 of these cancer centres are within one regional cancer network, and that in itself is a challenge because each of these 3 units in Dundee, Aberdeen and Inverness have actually very low volume. They do work collaboratively together. We have agreed national guidelines, but is this the best model? And that's something we are continue to consider. But the other important aspect is these are the cancer centres, but throughout Scotland we have numerous hospitals. So one of the things when we were setting up the network, established almost 20 years ago, was to have a lead clinician. I was appointed as the first lead clinician. We had an advisory board with representation from all of the different major centres. We had a funded manager who was responsible for a lot of the administration, and we had an annual education day. We subsequently added in an annual morbidity and mortality day where we reviewed all of the national mortality and major morbidity, and we started to produce an annual report based on some crude audit data. But the principle of having a managed clinical network was to have an integrated system for patient care that was more than just the surgery. It was about the whole process from primary care through secondary care and referral on to tertiary care. And it was to work towards nationally agreed guidelines so that every patient got the same experience and was offered the same treatment pathway. It was multidisciplinary and looked at the whole pathway with perhaps different stages of the management being done in different centres. So a lot of the diagnostics could be done to approved, agreed, similar protocols. The surgery might be done on one site, the chemotherapy in another, and then follow up with the general practitioner in a different manner, in a different location. So this was an integrated care pathway system. There's the 5 cancer centres, but what was really important was for all the small district hospitals to know who their point of contact was and to refer in a hub and spoke type manner. Some of the more complex cases came to Edinburgh because Edinburgh has the liver transplant unit for Scotland. It also has the biggest experience in liver and pancreatic surgery, and so a lot of the cases perhaps bypassed some of the other centres and came to Edinburgh for historical reasons. What our early data started showing us is where the bottlenecks were. So we could look at time from the GP referral to first assessment in the secondary care setting by a hospital consultant, when the definitive diagnosis was established in terms of the investigation stage, and then the timeline to first definitive treatment. And so that was all fine for primary cancers, and that's how the process started working. And we started getting national data, and as you see in the early days, and this is back now the last 7 or 8 years, the number of primary pancreas, primary liver, primary bile duct and gallbladder, indeed primary duodenal tumours, and you can see about 1,500 cases per year in Scotland. But at this stage we still didn't have any data on a national level of what we were doing with colorectal liver metastases. We could also look beyond the national and look at individual hospital and see where the population based was and where the hospitals were making the diagnosis. And you can see some of the major, Glasgow, Edinburgh, the 2 big units in terms of number of patients, and that's just a reflection of the population in those areas. But what we evolved onto after that sort of initial quantifiable data was to start developing quality performance indicators, QPIs, or key performance indicators, KPIs. And these were defined by each of the cancers. And here you can see, and again, this is still primary cancers only. At the start, we were only dealing with primary cancers, but all patients with an HPV cancer should be discussed by an MDT prior to definitive treatment. And you can see the description, numerator, denominator, exclusions, but a target that 95% of the Scottish population who had an HPV primary cancer should be discussed at a HPV MDT meeting. And this allowed us to start collecting data. The red line is that QPI, the 95%, and there's data over 3 years, 2019, 2020, 21. And you can see that in most of the health boards in Scotland, most of the hospitals, we're approaching or exceeding that target. So we're getting there with primary cancers all being discussed at an MDT meeting. Here's another one, mortality following a Whipple procedure, either for pancreatic, duodenal, or distal biliary tract cancer, looking at both 30-day and 90-day mortality with the target at the bottom there, 5% mortality at 30 days, less than 7.5 at 90 days. And this is where we focus down a bit more into the 3 regions. And you can see the data for Aberdeen, Inverness, Dundee has been, those 3 centres has been amalgamated, Edinburgh and Glasgow. You can see where the Whipples are being done and the Scottish data at the right-hand side of your screen. 90 plus procedures being done on an annual basis. And you can see where the mortality in 2020 just exceeded the 7.5% in Scotland, across all of Scotland. And that was COVID. That was a COVID year, and we have looked at those in great detail, and some of the early patients, unfortunately, post their resection developed COVID, and our mortality was slightly higher than it should have been. But this is the value of auditing and reviewing and analysing, and every mortality in Scotland in HPV cancer is looked at. Now, there are a number of guidelines nationally. In Scotland, we have the Scottish Intercollegiate Guidelines, and they started producing some guidance on surgery for advanced disease. And you can see the first bullet point, there is that patients with liver and lung metastases should be considered for resection, or in the case of background liver disease, ablation. And so we started getting some indicators of what we needed to for colorectal cancer. Likewise, for resectable liver metastases, all patients with liver-only metastases should be discussed at an MDT meeting, which includes a liver surgeon, taking the publication that we did on a UK basis many years previously as the evidence base for that. And unresectable metastases should be considered for downstaging chemotherapy. Again, a newer modality, a multi-modality treatment for those with initially unresectable liver metastases. There was also some other quality performance indicators for our primary cancer and colorectal cancer, and you can see that over the years those have been updated and revised. And we have lobbied that we get colorectal cancer and colorectal liver metastases into this guideline and quality performance indicators. And we've eventually achieved that. So now in the colorectal guidelines, there is one that patients with a new diagnosis of colorectal liver metastases should be referred. So it's now become a quality indicator for the primary cancer, the colorectal cancer, for those patients to be referred on, and it's a 95% target. And this is now some of the early data coming through from our colorectal cancer networks, and you can see there's about 88 that were referred, but that's only 66% of synchronous liver metastases. So we have a bit to go yet, but this is one of the very early and the first reports of that. You can see at the bottom, each case that didn't achieve that target that was looked into and an explanation given, and that's some of the comments right down at the bottom. Why the shortfall was 2 patients with rapid clinical decline and 2 with inoperable disease, but they didn't go through an MDT. So that's synchronous liver metastases, and that's metachronous liver metastases, slightly better at about 70%. So it's now in the colorectal cancer network targets, and it's also now in the HPV one, where we have a target of 30 and 90-day mortality for colorectal liver metastases. And again, we've got the data, and you can see some of the early data coming through of mortality following surgical, resection, and ablation of liver metastases from each of the 5 cancer centres. You can see Aberdeen, Inverness, Dundee in the north, Edinburgh in the southeast, Glasgow. And you can see some of the units have relatively small numbers, and therefore one mortality makes a difference in terms of 90-day outcome. But overall, across Scotland, we know our data is within acceptable limits, and we work as a managed clinical network. Likewise, for ablation, one centre slightly over because of small numbers, but when we look at it nationally, we're probably acceptable. And this is going to drive change. This is going to drive perhaps amalgamation of those 3 units in the north of Scotland. So in summary, I think there's a huge benefit to having regional cancer networks with defined referral pathways, agreed national, if you can achieve it, management guidelines, audit that practice, and agree some quality performance indicators to see how your service is clinically improving, and ultimately that's for safe patient care and better outcomes. Thank you very much.
Thank you very much, Professor Parks, for the excellent presentation. And may I now invite Dr. Nuraj Joseph to talk about the chemotherapy for colorectal metastases from the Sri Lankan perspective.
Thank you for the opportunity to present at this distinguished symposium. So briefly, I will introduce some of the agents that we use and how treatment in our setting compares with international guidelines, and then I will finally conclude with a case scenario. So when you look at systemic treatment for metastatic colorectal cancer in the context of resectable liver metastasis, mainly it's the conventional chemotherapy agents, and you also have the novel biological agents, cetuximab, panitumumab, and bevacizumab. Now, chemotherapy-wise, we have 4 drugs, 5-fluorouracil, oxaliplatin, and irinotecan. There is an oral alternative for 5-fluorouracil, and that's called capecitabine. We give chemotherapy in combinations. Oncologists are fond of using various terms for this. So FOLFOX is a combination of 5-fluorouracil with oxaliplatin, and FOLFIRI is 5-fluorouracil with irinotecan. You have the same combination with using the oral drug capecitabine instead of 5-fluorouracil, and it's called Capox and Capiri. You can, in rare situations, if you want a good response, you can combine 5-fluorouracil, oxaliplatin, and irinotecan. It's a fairly toxic regimen, so you call it FOLFOX-IRI. So the main debate surrounds infusional 5-FU versus capecitabine. Now, there was this belief that infusional 5-FU is better than capecitabine, that it has a better response. But as I will show you, data doesn't really, modern data doesn't show that's no longer true. So the problem with infusional 5-FU is that it has to be delivered as a 46-hour continuous infusion. So you need an ambulatory infusion pump, or otherwise you would have to keep the patient in ward till the infusion is over. It needs central venous access. You're delivering chemotherapy every 2 weeks as an infusion. There's more neutropenia and more oral mucositis. The advantage is, however, that you have less hand-foot syndrome and less diarrhea. Capecitabine is a very convenient alternative in our setting because it's an oral tablet. You give it twice daily for 2 weeks. So this is an ambulatory infusion pump, and you need a central venous access. So in our setting, this is virtually not feasible. A few patients on a case ad hoc basis have been treated with infusional pumps, but it is not routinely followed. So what does the data show? Is FOLFOX actually superior to Capox? There is no difference, and this is just one trial, but a meta-analysis has concluded both in the adjuvant and in the metastatic setting. There is no difference between FOLFOX and Capox, and in fact, in the adjuvant setting, there is some data to say that Capox might be superior. So in our setting, we do have capecitabine and oxaliplatin. So just because we are unable to deliver infusional 5-FU, there is no major detriment to our patients. You can combine capecitabine with irinotecan, but of course diarrhea is one of the main side effects with irinotecan. So you're actually combining 2 agents that can cause diarrhea. But again, data shows that FOLFIRI is equal to capecitabine and irinotecan. So again, even if you want to use irinotecan in our setting, you can still combine it with capecitabine. So the inability to deliver infusional 5-FU is not a major cause for concern. If you want to combine the 3, of course, it's still possible to combine capecitabine, oxaliplatin, and irinotecan, but not much of data on that aspect. So if you want a good response, if you want to convert a patient who is initially unresectable to a resectable state, and you want a good response, and you want to combine all these 3 agents, of course, that is a challenge in our setting. So about 5% of patients, whether it's 5-FU or capecitabine, it is degraded by the enzyme dihydropyrimidine dehydrogenase. About 5% will have a deficiency in this enzyme. And if you do not test for it, and you give 5-FU or capecitabine, it can cause increased toxicity. Internationally, it is recommended that DPD testing be done before you offer 5-FU or capecitabine. So as far as our setting goes, this is not available routinely in the government sector. So that is one of the shortcomings we have. If you do have a DPD deficiency, it's still possible to treat, but you have to reduce dose. So what about biologicals? Now, Again, I will show you the data related to cost. So biologicals are not available since the economic crisis in our setting, biologicals for colorectal cancer. But does it matter? So in the context of resectable liver metastasis, the EPOCH trial showed that the addition of cetuximab did not improve outcomes. And in fact, if you see here, the cetuximab arm did worse than chemotherapy alone. So we shouldn't get disheartened just because we do not have cetuximab. It does not really have, it does not cause any detriment to outcomes as far as resectable liver metastasis is concerned. What about the other biological bevacizumab? So this was the Prodigy 14 trial. They looked at the addition of cetuximab or bevacizumab depending on the RAS status. Again, there was no difference in outcome. So as far as, and this was in a group of patients who underwent liver resection. So if you have colorectal cancer and you're looking to resect the liver metastasis, biologicals, the addition of a biological probably does not make a difference. Cost effectiveness, so this is data from, this is local data from the medical supplies division. So if you look at cetuximab, it costs for LIFE again, because we do not have quali data in our setting, we did a study looking at LIFE again. Just the drug costs $89,000 US. So you can imagine it's prohibitively expensive. Bevacizumab is slightly cheaper. But this is just drug cost. If you look at indirect costs, costs of treating complications, the central venous access and so on, it's much higher. And if you look at, if you adjust it for quality of life, it's still higher. So for cancer drugs, the College of Oncologists, we were the first college actually to come up with an essential drugs list. And we chose this threshold of a LIFE again, or cost per LIFE again, or quality adjusted LIFE again of $10,000 US, which is 3 times the per capita GDP, which is used as a threshold. So cetuximab and bevacizumab do not meet that threshold. So we enter this debate. So you've just heard there is no evidence to say the colorectal resectable liver metastasis is an area where there is a lot of controversies. There is certainly no evidence to say that actually preoperative chemotherapy improves outcomes, as shown in this EORTC trial. But in our setting, where we have challenges, as Professor Rohan Sirivardana showed, there are limited liver units. So if you're selecting patients, doing a RAS-RAF molecular test will be useful. Because as you can see here, if you've got a BRAF mutation, your survival is, median survival is about 50% at 1 year. So median survival is 12 months. So this is a group you probably should not be doing upfront a liver resection. You should probably be giving chemotherapy first to see whether the disease biology manifests itself. I'm not saying that you should not resect the liver metastasis, but probably give chemo first. If there is a response, if there's no progression, then you could go ahead and select. So RAS-RAF testing has its place. It's not available in the government sector. It's not very expensive, but I think if you factor in the cost of liver surgery, it is something cost effective. So that is something we should look to introduce, even though we would not actually change the systemic treatment based on the RAS-RAF status. So moving on to treatment algorithm. So which patients do I think should get upfront chemotherapy? If it is resectable upfront, I certainly think if you do the RAS-RAF mutation and it's BRAF mutant, these patients should have chemotherapy first. If you have sort of bilobar disease and more than 4 metastases, maybe it's worthwhile giving initial chemotherapy. Let the disease biology manifest itself, and so that you can then prioritize your liver resection. So how do we compare with the international guidelines. So upfront resection is certainly possible if the surgeons do have a theater slot and ICU slots and so on. We do not have molecular testing, but if required, we can deliver neoadjuvant chemotherapy and also short course radiotherapy for patients with rectal primaries. So the benefit of biologicals are anyway doubtful. So as far as systemic treatment is concerned, we can deliver something that is safe and effective for our patients. If you want a very good response, then of course delivering the FOLFOX-IRI combination of irinotecan together with oxaliplatin is challenging. We do have issues with radiotherapy for rectal cancer as well if you've got a rectal primary. But basically, we are able to offer something which is comparable to international guidelines in our setting. And these are the cancer treatment centers. We have 24 cancer treatment centers that offer chemotherapy. They are located throughout the country. In every district, you have a center which can deliver chemotherapy. You have 7 centers that can deliver radiotherapy, and 5 have a linear accelerator. So I'd like to conclude with this scenario. Professor Rohan Siriwardana showed you a map, and I'm going to show you another map. So this is a patient in Kandy. This was in the middle of the economic crisis. There was a patient with a rectal primary with liver mets on the in the left lobe. So the patient was from Kandy. So the patient had the investigations in Kandy, but they found that the linear accelerator in Kandy had broken down. So there was a slot available in Batiklo. The patient goes here to Batiklo, has the short course radiotherapy, and the surgeon in Kandy very prudently decides to operate the rectal primary. And then when it comes to chemotherapy, we had a shortage of oxaliplatin, but one of the patient's relatives was in Hambantota, and Hambantota being Hambantota had oxaliplatin for some reason. So the patient travels to Hambantota to receive chemotherapy, and then has the liver resection done at the National Hospital in Colombo. So you can say that our system is broken, but I think in the middle of the economic crisis, in the middle of all these drug shortages in anesthetic drugs and so on, in the middle of the economic crisis, a patient with resectable liver metastasis and a rectal primary did manage to receive a curative treatment. And I think it is a tribute to our health system and everyone who works in it, that we were able to deliver this treatment free at the point of delivery. So in summary, we can deliver most of the chemotherapy agents. We have challenges in delivering infusional 5FU. Biological agents are, of course, prohibitively expensive, but of marginal benefit. We need to introduce molecular diagnostics to improve further outcomes. Thank you very much.
Thank you, Nurad. I think we've had a fascinating symposium which has highlighted key issues in the management of colorectal liver metastases, which touch on both training and systematic healthcare networks. So we'd like to have a little more time, but we've got just about 10 minutes for questions and discussion. And I open it out to the audience for questions.
Until audience comes up with a question, can I ask a question from you, Michael? You said in your assessment of trainees, you would assess the quantity as well as, more importantly, the quality. So how do you assess the quality objectively, especially removing the personal bias?
Is this for operative as well?
Yes, I'm talking about trainees operating and scares.
So there are domains that we look at, and it's the level of operating that are given, whether they can do it supervised or unsupervised. So that aspect is fairly straightforward, isn't it? The quality of operative competence is not assessed because you can't benchmark that. It's looked at indicative numbers. If you're looking at the quality of the other domains that I spoke about, those are looked at, and there are drop-down menus that we can choose and look at different aspects of how that is delivered. So I don't think I answered your question, because you cannot objectively sort of grade quality of how a procedure is done.
I guess one of the tools that we have available to us are workplace-based assessments. So for some of the index operations, you can either give formative, or sometimes it's played into summative assessment of a major procedure, so an HPB, a liver resection, or a pancreatic resection, and you can break down, and we have the tools available to look at each step of the procedure and indicate where development is needed. So it's not a measure, as Mike said, of the quality, but it helps in that sort of feedback to trainees of areas of a procedure where they could focus on and try and improve. And I think that's one of the things about training that has improved over recent years, is that feedback, and particularly around some key procedures. So it doesn't measure quality of the outcome of the procedure itself, but perhaps allows a bit of certainly feedback to the trainee on their operative technique.
So is it more like a formative assessment that you use, the workplace-based assessments, or is there any summative aspect as well in that? Is it only a feedback?
It's mainly for formative feedback. You know, it's mainly for feedback, and that's where Mike said we've had a change, because it used to be that work-based assessments were the be-all and end-all. That's how trainees and their end-of-year review was undertaken, based on those work-based assessments. But it became a bit of a tick box, and so it has evolved into a more holistic methodology, as Mike explained, with multiple consultants giving sort of more an overview of those capabilities in practice. So it's a more holistic view is now undertaken. But yet workplace-based assessments have their part, but I think more in the formative feedback area rather than summative feedback.
If I may just elaborate on what Rowan was saying about the multi-consultant report. And by and large, most of the trainees we have in, for example, Sri Lanka or even in the UK, when they get into training, they're competent, they're good trainees, but there's a subset who probably need further training, need focused training, or very rarely shouldn't be doing that subspecialty or specialty at all. And it became a trend that picking those ones out, especially when it comes to us assessing them at key points of their training, it's difficult to pin down as to what the problem is, and also whether this trainee should progress or not was not actually documented, because the educational supervisor would not state the obvious. So while we knew that there's a rumor that this trainee is not performing well or needs a little bit more attention in certain aspects, that wasn't picked up. And that is something that we've overcome with the multi-consultant report, because it's easier for us to give an opinion as a group and suggest certain focused developments rather than one individual stating that fact about another. And that has made an improvement, and it helps us with the assessment very much. Does that make sense?
I have a question really for both Rowan. Probably you looked at the evolution of how you got HPB referral networks going in Scotland, we are sort of still in a very, as you've heard from Rohan's talk, in a very primitive sense there. So there are several aspects. One is, as Rohan alluded to, guidelines. Having guidelines is something, one is having contextual guidelines for our country. Nurad pointed out the economic aspects of certain things and applicability to us. But then enforceability or compliance with those guidelines, compliance with referral networks, and a very important point that again I allude to what Rohan made is having MDT meetings, but the quality of MDT meetings, and these are anecdotal observations of some of the decisions that we see made at MDT meetings may not necessarily reflect best care. So the quality of that. So taking, because at the end of the day, these all factor in to be able to give care, and the care should be prioritized, as Nurad was saying, otherwise it becomes very random. Now, what was your experience in your early days in getting compliance? What were the carrots you all used? What were the sticks, if at all, that you used to get these networks or these processes moving?
Yeah, great question. And it was an evolution and has been an evolution. It's been clinically led. I think that was important, but had the backing of the Department of Health. They wanted to see this because they saw it in other countries. So in our context, it was similar to what you've just said, relative to our geographical and financial restraints. So there were financial restraints for us in setting it up and initially in getting even funding, because HPV cancer wasn't a priority at the start. So the big four were breast, lung, colorectal, and I think GI, upper GI. So there was four big, they started several years before we could encourage our Department of Health in Scotland to do something for HPV. So there was a lag. But what we sat down, and the very first thing we did was try and come up with common protocols and common guidelines that were going to work for us in Scotland. And that was around diagnosis, treatment pathways, and standardizing management protocols. And it was essentially that, but it was looking at our context in Scotland. And that included oncology. So oncology were a big bit of that. It included radiology in terms of the workup and the protocols for doing, initially it was CT scans. We didn't even have MRIs and PET scans included in the very initial guidelines, but those were reviewed annually. And then after that, the next priority was to audit. And the very first audits were literally counting numbers of how many index patients we had and how many of them had oncology treatment as their primary treatment, how many of them had surgery or other techniques such as ablative techniques. So the crude data the first few years was very crude, but that allowed us to have an annual meeting, one meeting every year, where we got all the interested parties together, and that grew. So the first few years it was only a handful of us. It gradually grew year on year. And we used that to evolve the audit data and trying to collect a little bit more. And it's only relatively recently that we've got to the stage of having QPIs and performance standards. So in essence, that was a 10-year journey. So I think the concept is start with guidelines, agree those if you can on a national level, and then start with very simple, basic audit data, which might be just counting numbers, and then evolve that into quality and improvements. And it's grown and grown. What we've now added on is an annual review of every death. Now, the other cancers with big volumes like lung and colorectal, I don't think they do that to the same level, but we can do it because we're talking relatively small numbers, and we analyze, and on a network basis, the whole country, we sit down and look, is there anything we could have done that would have avoided that mortality and that death? So it's a very educational process now, as well as now, I think, having pretty robust data.
Thank you, Ron. I think we like to carry on this conversation much longer, but we can't literally eat into tea time. So once again, on behalf of the Sri Lanka Surgical Congress, let me extend our gratitude and thanks for the excellent presentations today. And as a token of appreciation, we have some of these, and these are books on the history of surgery in this country. So Professor Rowan Parks, Michael Silva, Nuraj Joseph, and last but not least, Rohan Sirivarna, Prof. Rohan Sirivarna. Thank you, everyone. And that brings the symposium to a close.